Hey there! Today we go into some ethical issues raised by the practice of medically assisted death, which is still quite controversial in our society. So let's get started. When a 70-year-old patient, Lillian Boyce, suffering from a terminal illness and severe pain, asked Dr. Nigel Cox to administer a lethal dose of potassium chloride to end her life, what she asked for is what we call voluntary active euthanasia, or VAE. Now, if she had taken her own life by administering the drug herself, she would have engaged in what we call a physician assisted suicide, or PAS. Both are forms of physician assisted dying and are illegal in many places. Still, historically speaking, doctors who engage in it are rarely prosecuted, even if they are reported, because the intent of these doctors are often interpreted to be benevolent. But many medical associations, such as the American Medical Association, do not support such a practice and instead recommend foregoing life-sustaining treatment or terminal sedation as alternatives. Although ethicists disagree on its ethical implications, the relevant difference between foregoing life-sustaining treatment and PAD is that the latter directly causes the death of the patient, while the foregoing of life-sustaining treatment merely allows nature to take its course, even if it might speed up the dying process. Now, this is a distinction made by those who affirm the philosophical viability of what is called the principle of double effect. So let's take a look at this principle, the principle of double effect. The principle of double effect, or PDE, states that a morally permissible action must meet all of the four following criteria. Number one, the act itself must be either morally good or at least morally neutral or indifferent. Number two, the agent may not positively will the bad effect, but merely permit it. You can permit or anticipate the bad effect, but you cannot intend it. Number three, the good effect must be produced directly by the action and not by the bad effect. So the good cannot be dependent on the bad. Otherwise, the agent would be actually using something bad, something evil, in order to produce a good result, which is never allowed. And number four, the bad effect cannot outweigh the benefits of the good effect. So let's see how these criteria can be applied to a particular case. So let's suppose that there's a runaway trolley that is heading down a track where 10 people are tied to the track, right? So if you leave the trolley alone, it would eventually run over all 10 people. Now, as a pedestrian looking at the trolley, looking at this scenario, you also have access to a switch that will divert the trolley down a different track where there is unfortunately a jogger on the track, right? And that person will be killed as a result of the diversion. So you press the switch in order to save 10 people, but it leads to the death of merely one person, the jogger, right? So if you do that, have you done an evil act? Well, according to the principle of double effect, you did not, right? So let's take a look at the four criteria. Number one, is the act itself morally neutral? Well, the act of diverting the train is itself a morally neutral act. And did you anticipate or intend the death of the jogger? Well, the agent can say you did not intend the death of a jogger, but merely anticipated, right? So, and then three, you are saving the saving of 10 people's lives does not depend on the death of the jogger itself. So say if somehow the jogger escapes the track, didn't get hit, ends up surviving, well, all for the better, right? So the good effect of saving 10 people does not depend on the death of the jogger, which is a bad effect. So it fulfills principle or criterion 3. And then lastly, the good effect of saving 10 people clearly outweighs the bad effect, which is the death of one person. So it also fulfills criterion number 4. So according to the principle of double effect, then there is a moral difference between anticipating a bad effect versus intending, right, the death of a person. So what do you think about this? Clearly, the principle of double effect is not persuasive for everyone, especially in the case of physician-assisted death. Because those who wish to engage in physician-assisted death often have compassionate intentions to either want to end the suffering of a patient or to honor the patient's autonomy. So the intention behind physician-assisted death makes it different from other sorts of malicious actions that most people would find morally objectionable. So any action that causes or hastens or speeds up a patient's death for compassionate reasons is called euthanasia. So both the foregoing of life-sustaining treatment as well as physician-assisted death are both forms of euthanasia. While the former is passive euthanasia because no action is directly taken to cause the death of the patient, right? While the latter is called active euthanasia because an action is taken to directly cause the death of a patient. So foregoing life-sustaining treatment for the reason of medical futility, that the treatment that such as not going through with a treatment that would not bring any benefit for the patient, is not considered euthanasia because the intention is not to speed up, right, or to speed up the dying process. So some would consider it, however, that foregoing life-sustaining treatment that would actually prolong life, right, even if it might not cure the illness, is still a form of passive euthanasia. So to forego a treatment that can prolong life is also considered by some to be a form of passive euthanasia. There are two more controversial forms of euthanasia: involuntary as well as non-voluntary euthanasia. Non-voluntary euthanasia is more controversial because it concerns those who are terminally ill but lack the decision-making capacity, right? Those who are unable to consent to death, right? Such as those who are suffering from a coma, right, or some kind of mental disability. Even countries that legalized active euthanasia in a form of physician-assisted death do not legally permit non-voluntary euthanasia precisely for this reason, that the patient cannot consent to that process. Involuntary euthanasia in the clinical setting is universally rejected as unethical, right? In the case of patients who are actively causing historically speaking, physician-assisted death has been more successful in gaining public support precisely because in the case of PAS, providers are not directly involved in the death of the patient, right? However, the proponents of voluntary active euthanasia object that by only permitting PAS is unfair to patients who are unable to administer the medications themselves, right? For instance, patients who are suffering from a late-stage Alzheimer's or suffering from paralysis are incapable of administering the medication. So that in these cases, there should be providers who help administer the drug for them. So consider the case of Tony Nicholson, right, who suffers from locked-in syndrome as a result of a stroke. While totally paralyzed and mute, he remained conscious, and so he desired to end his life because of this suffering. But he could not obviously self-administer the drug to do it. So even if physician-assisted death is permitted, there is nothing Tony Nicholson could do. So proponents of voluntary active euthanasia say that there should be providers who are permitted to administer the medication for patients like Tony. Others object that the medical profession's commitment to non-maleficence ultimately means that providers should not aid in the death of a patient because death is never in the patient's interest. However, there is no agreement on whether death is in the patient's interest in some contexts. So recently, physician-assisted suicide was legalized by Oregon's Death with Dignity Act in 1994. Soon after, Washington, Vermont, and California followed. In all of these cases, patients have to, number one, be at least 18 years old and capable of making autonomous decisions. Number two, have a terminal illness certified by 2 doctors and are said to have to be confirmed that they will be likely to die in the next 6 months. Number 3, they have to make 2 oral and 1 written request for PAS to the physician. And there are also obligations on the part of the physician as well. Number 1, their participation in any form of physician-assisted suicide is optional, right? So they can opt out. Number 2, they must be licensed in the state in which they're performing aiding the patient's suicide. Number 3, they must inform the patient of alternative treatments, palliative care, for instance. Number 4, they must also ask the patient to notify next of kin so that they can, presumably talk about this with their family members. Number 5, they must, if physicians discover that the patient is incompetent to make a decision, the physician must refer the patient to a psychological examiner to determine competency. If all of these conditions are met, there's still a 45-hour waiting window that must be honored before a patient can pick up the drugs. So let us take a look at some philosophical arguments. For consequentialists who value the minimization of pain, they might argue that physician-assisted death is actually morally obligatory for providers if the patient requests it, because it is the duty of a moral person, any moral person, to maximize happiness and minimize pain. So for some consequentialists, pain that cannot be managed is worse than death. So it follows that death can be in the interest of the patient in some context. Others argue from the perspective of patient autonomy and self-determination. Now, this view is softer than the consequentialist argument because it does not say that providers are morally obligated to assist in the patient's suicide, but merely argue that it is permissible for them to do so, given a patient's right of self-determination. One objection is that physician-assisted suicide compromises the integrity of and trust in the medical profession itself because it conflicts with the provider's purpose to heal and not to kill. Now, critics point out that medicine has more goals than simply healing, such as preserving patient autonomy as well as the quality of life. Others say that physician-assisted suicide leads to bad social consequences, such as abuses of the practice, or when those who are poor or suffering from social marginalization in a society make use of physician-assisted suicide in order to escape their circumstances, right? While the more wealthy and powerful members of the society have less of a use for it. In these types of situations, then we're bringing a medical solution to a problem that should be solved socially, which is a moral issue. Now, critics point out that, however, that there's little evidence that would justify such worries, even if these worries cannot be dismissed out of hand for lack of evidence. The strongest objection, however, I think, is the argument from the sanctity of life. This is the argument usually made in religious ethics, such as Christian ethics, though not all Christian ethicists agree on what its implications are. It states that human life generally is sacred and valuable in itself because human life is first related to God before it is related to us and to one another. Therefore, any action that violates the sacredness of human life or cuts it short is forbidden. Now, critics point out, however, that there's no convincing evidence that even for God, that human life should be taken in the abstract apart from quality of life considerations and that bare lives has a kind of absolute value. Other Christian theologians like Richard McCormick argue that physician-assisted suicide is a flight from compassion, because some patients who ask for it are afraid of becoming dependent on others. McCormick believes that this really amounts to the denial of human vulnerability and dependence, and fosters a culture where we might no longer see value in the lives of those who are defined by society as burdensome, right? Critics point out, however, that far from being a flight from compassion, physician-assisted suicide is really motivated by compassion, right? It motivates providers to assist in patients dying in order to end their suffering. So there are these various considerations back and forth between those who are for and against. So, what do you think? I hope that we can continue this conversation on our discussion board.